Thank you all for joining us today for our June 2020 Lightning Speed Crowdsourcing event. This is a very exciting topic, and I know I say that every time, and every time I say I mean it, but I really do mean it this time. So we are talking with some really excellent leaders today about equity in healthcare. This is a conversation that we have always been having, and it's always important. And we've been able to find some excellent researchers who are bringing us some great content today. But just some quick housekeeping about our topic today. So each presenter will have 12 minutes total, so lightning speed indeed. Well, the biggest thing here is that today's session is being recorded, so please be mindful of that. We really encourage audience participation today. It looks like we've got a good number of folks on the line. Thank you for joining us. If you have any questions, do feel free to either chat them to us in the Q&A portion or to raise your hand in the participant box, and I will unmute you to ask your question. That's always kind of a fun Wild West aspect there. And then after today's live session, do please join us on Dime's Slack on our Lightning Speed Crowdsourcing channel so that we can continue the great conversation and be connected with each other after today's live event. Let's go ahead and get started here. I'm really looking forward to jumping right into these presentations. So we have two excellent presenters today, and we'll start off with Lynette Hammond Gerido, a doctoral candidate from Florida State University. And then after her presentation, we'll jump, excuse me, to Jorge Rodriguez, a clinician investigator at Brigham and Women's Hospital. So Lynette, I'll go ahead and pass the ball to you.
Hi everyone, and thank you so much for having me here today to talk about a recent paper that I published called Racial Disparities in Breast Cancer and Genomic Uncertainty. Could you go to the next slide, please? Just a quick about me and the type of research that I do. I am about a community-based participatory model. I work with patient advocates, and I look at research in ways that we start with people first. And so patient advocates are centered. That's us in the corner there at the Capitol for civic engagement, out in the community, you know, serving the community in which you're part of. Researchers should be a part of the community. I know sometimes people talk about things of bias, and we'll talk about that, but also in the classroom. I'm an information scientist, so our labs look a little bit different than others, but then we present these findings at different conferences and publications and things like that. So just the key is starting with people first. Next slide, please. The types of things I use is population data. Like for the first thing is kind of visualize racial disparities and things like that. My dissertation topics about BRCA testing decisions, which is a genomic testing for breast cancer. I also look at how vulnerable populations interact with health information and use different models for that. And then the last thing is really just looking at ways to engage patients and everyday people in medical research beyond being volunteers and participants, but also influencing the study design and thinking about ways that we can translate findings from our studies directly to those communities. Next slide, please. So for this particular paper, we looked at a population data set called the Health Information National Trends Survey. It's out of the National Cancer Institute. It's publicly available. You can download this. They do it each year. And it has information about like where people get their health information, who they get it from, do they trust it? And then they kind of include other indicators about lifestyle and health, and sometimes even cancer diagnosis. The sample size is usually about a little over 3,000 people. Next slide, please. And so the paper that I'm going to discuss was a mini review of other studies that had used this data set and how they translated it in terms of this genomic testing for breast cancer, in particular BRCA testing for mutations in the BRCA1 and 2 gene. Next slide, please. And so the first major thing that I wanted to look at, and I did a QuantCrit review of it, is like I critically reviewed it for understanding of like bias and things like that, that there's overarching themes about the racism that exacerbate situations. And we recognize that data must be interpreted, but data has to represent diverse populations. So this is a great opportunity, you know, with this data set, which is population based, and be able to, for researchers to use it. And so, but there still can be challenges. So next slide, please. One of the things that we found is like, you know, when you look at these, I'm showing you the distribution. So when you look at the distribution of the people who responded, the one in the back is, I really just want you to look at the shapes of them. The one in the back, these are the distribution by age. So the one in the back, and it's dots, it shows that there are people who are like age 50 to 64 are the predominant number of people who have responded to this data. However, once it's weighted, you see the distribution mirrors more of what the generalized population is. And so that makes the numbers at the lower end go up. The challenge with that is that fewer people are responding in the younger groups, but their responses carry much more weight in the data set once you're using it. So even though it may seem like it's generalizable, especially when it comes to breast cancer, genomic testing and things like an early onset, you know, a lot of the people that we would be looking at or interested in for this particular study would be in the lower than 50 range, because that may be a target age group for of interest for my studies. Next slide, please. Another thing is that data can't speak for itself, and sometimes the tool doesn't reflect like cultural nuance or things like that. And so they ask the question in several ways on this every iteration of the study of like, have you heard about genetic tests? Do you know that they're used for health? You know, and they use this to measure awareness. The awareness was like, you know, I'm sorry, when you use it to measure awareness, and sometimes that's not really true of whether they were aware of genetic testing or not, but they actually could be using different terms for it, like paternity testing or maternal DNA testing, things like that, fetal DNA testing. Next slide, please. So information, health information is also in everyday life. It's not just in these surveys or one-on-one with clinicians. Sometimes it's, you know, through podcasts and things like that. So a story for me is that, you know, I was listening to the Super Soul Sunday Conversations. Oprah and will.i.am have not endorsed my studies, but I would love it if they would, just as a disclaimer. So they were talking about AI, and Oprah was kind of concerned about it, like, ooh, that's creepy. It's, you know, these decisions, and will.i.am's position was, hey, they're creating all these scenarios to figure out like smart cars and self-driving cars. What are they going to do if they encounter something where there's a decision where they have to hit somebody or not hit somebody? And next slide, please. This is the age-old trolley car problem. That's a ethical decision where, you know, you have to determine if the trolley car is going to hit these people or 5 people to save one, or potentially hit one person to save 5. And we start thinking about that there's framing for all of this. And I was just like, wow, this is interesting. And people think that it's really big, bad, you know, AI. But, you know, if you go to the next question, this is actually what researchers are studying. Go to the next slide, please. I saw when I was online this article from Awad et al., and it was about the moral machine experience. They were actually studying whether people were, you know, what people thought the self-driving car should do. Like, should it move if the pedestrians were elderly people, or if they were children? These types of things are going in. And I had to tweet about it. So you can get information and help information about innovations in the digital space as well. So this is tying into kind of hints where people are looking to social media and also to get some of this cutting edge advances and innovations. Next slide, please. But the bottom line is that we must use ethical principles to guide our work, right? So there is a legacy of information available, and philosophy and frameworks that we can use to help drive our work, and that we should incorporate that into our work. Next slide, please. And this is the last one. And because when we use inclusive design principles, and we try to avoid some of those blind spots by having inclusive teams, diverse populations for usability testing and things like that, we can create more advanced systems. And one of the great things that I learned about, and many of you, was that there's an AI tool that MIT came up with that worked equally well for detecting breast cancer 5 years in advance. So AI is not always bad. It can be used for good, but we need to make sure that we establish checks and balances in our process, and that we are including people at all levels, not just in the study as participants, but also in the workforce as researchers, and on the product development team. Thank you.
Okay, Lynette,
There's my
thank you.
contact.
Yes, yes, thank you so much for your excellent presentation, Lynette. I am particularly struck by, well, let me do a quick shout out too. If anyone continues to have some questions, do feel free to either raise your hand in the participant box or put them into the Q&A chat function. But Lynette, fantastic presentation. I'm particularly struck by your statement where you say, don't assume technology will be liberating, right? The tools that we make are only as good as we make them. I think that's something for us to really think about here. We do have a question from someone, and slides will be available afterwards too. So do feel free. I think we'll make them available just within just a couple of days. And so also your slide about how data is not neutral. I think sometimes we assume that, you know, science is a great truth, and it can be, and it is, but it's the responsibility of all of us to be sure that we're looking at that data in an equitable, fair way. And so I really appreciate you bringing more information about that and your research too. I do have a question for groups who are starting to looking at their data sets. How can groups who have these really informative, fantastic data sets, such as hints, for example, how can people look at their data sets to be sure that this is something that would be useful, or we can kind of self-audit?
Right. So I want to be clear too, is I think going through that exercise of just understanding the limitations of your data, because I think it's great, you know, if, as a researcher, to have that access to that type of population level data, or at least for such a large sample size, is huge. However, you sometimes need to follow up. And so one of the things that I'm following up on in a study now is just really doing a more qualitative a study where it's interviews with people and asking breast cancer patients, you know, what are some of your challenges? Do you know about these things? So that I can get a more rich feedback than just the yes or no response that I got from hints.
Yeah, I think that's great. I think that sometimes getting a bunch of, you know, yes or no answers, or A, B, C, or D, or whatever else too, can be really useful, but the quality behind the data and the stories from patients too are also enormously valuable, and I think sometimes it's overlooked. And that actually is a great segue into a question that we had from an attendee asking, how do groups, research groups, partner with patients as equal members of a team in this work when trust is so deeply broken in health tech and health development?
Right. I think that this has been a huge question. And I think sometimes the first step is transparency, right? And transparency, and also intention. So your intention has to be that you're creating an inclusive environment, right? So when not just that there are going to be roles that people have to have specialized skills to play, but knowing that there is a role and an opportunity for feedback. So usually good best practices in product design means that you are iteratively you know, reaching out for feedback from people who would be either end users or also impacted by your designs. And so I think there are opportunities there. In addition, sometimes you have to think about different roles. Everyone doesn't have to be a coder to be on your team. Sometimes, you know, you have information ethicists, you have different people that can bring something. You can partner with citizens to be, you know, data scientists. You can also think about art students or people who are into history. There are plenty of people that can give sometimes perspectives and context to things that you may enrich your teams with. Now, that doesn't mean that you throw in everyone but the kitchen sink, because sometimes you just don't have time to do all of that. But you do have opportunities throughout each phase of the product development cycle to incorporate feedback from other people, or even to do some type of beta testing, partner with a advocacy group and see if maybe they might do a focus group with them and talk to them about that. And in particular, organizations like DIME, you know, having your network, I think it's amazing being able to connect different people at various levels of research for mentorship, and also feedback in these types of presentations that you're offering is very helpful.
Lynette, you are so good. Thank you so much for doing the shout out for DIME. John, I see you have an excellent question, and I should skip it because of time, but I'm not going to. So the question here from John Novak, one of our great DIME members, talking about how, Lynette, you opened your conversation about partnering with different patients and patient groups. So this question is, given the scope of your research and your background, have you been focusing primarily on breast cancer organizations or other therapeutic area specific groups, or focused on other minority groups such as Black members in the community, not necessarily breast cancer, or both, neither, something else? And what have you learned from that experience? And if you don't mind, sorry, if you could make your answer pretty succinct, sorry about that.
All right, long question. So yes, multiple partners. So Brave Bosom, Andrea, I see you on the call. Florida Breast Cancer Foundation, My Breast Years Ahead. There are a number of different advocates that I have, patient advocates for breast cancer in particular, because for my dissertation, I really wanted to specialize on it. However, we also look at data, so I look at data science for social good. I look at the Southern Data Science Conference, data for Black Lives, as well as just American and some professional associations like American Public Health Association. I'm involved in that. And so I think for the types of research that I do, I look at partnerships to understand not only the needs as a patient and, for the disease, but also for myself as a data scientist or an information scientist, making sure that I am aware of the tools of the trade, things about being able to create, privacy measures and things like that to protect data and understand the concerns, because there are some genuine concerns, for how information, this type of sensitive information is used. And a lot of times we're thinking about, oh, these are great ideas. We want to do this mobile intervention. We want to do these things. But, there's all kinds of concerns about the level of surveillance that we're doing in the name of good, on people. And we need to be able to listen to those concerns and understand that they're genuine, and that maybe we should be putting efforts into making sure that we're not only trying to improve outcomes, but that we're not creating or reifying old ills.
Lynette, fantastic answer to that very long conversation. And I think it's actually a perfect segue to Jorge. Lynette, you're now off the hook for the presentation. We'll jump to our next presenter, Jorge Rodriguez, clinician investigator at the Brigham Hospital. So Jorge, I'll pass the floor to you. Thanks again, Lynette.
Awesome. Thank you, everyone, for making the time on this Tuesday afternoon during lunchtime. I'll be reflecting here in a few slides on our recent piece that came out in JAMA with a similar title. Briefly, I'm a hospitalist, and I'm an technology equity researcher at Brigham and Women's Hospital and Harvard Medical School. And I always say that my passion sort of lies in the intersection of medicine, social justice, and technology. So somewhere in that overlap is where I try to live. So we can move on to the next slide. So I have no disclosures to report. We can move on to that slide. So for the purposes of this talk, I just want to kind of ground us in what I'll be sort of talking about: digital health, virtual care, there's all these different terms. And so for the purpose of this talk and for the purposes of our thought piece, we really focused on patient portals, mobile health app, and telehealth as sort of these primary patient-facing technologies that exist within the healthcare system. Patient portals, of course, sort of have been kind of the primary digital touch point for patients as part of healthcare systems since, forever, but at least since 2009 when the HITECH Act came out. Mobile health apps obviously sort of have both kind of industry as well as just anyone can really make a health app to some extent. And then telehealth app, of course, is all the rage. It's been around for a while, but with COVID, it's sort of picked up a bit more. And so the next question I'll try to answer over the next two slides is really going to be like, why am I talking about this? So if we go to the next slide, so there's two reasons. The first reason is the 21st Century Cures Act. So the Office of the National Coordinator released the final rules for the Cures Act, which essentially provided some structure and some guidance around data governance specifically for patients. And I sort of highlight these two quotes out of their sort of like one-page debriefer, though you can definitely go in and read the whole Rules Act. It's sort of fascinating. But essentially, this final rule gives patients more access to their data. And allows them to interact a little bit more easily through patient portals and mobile apps. And to some extent, it's essentially taking the structure, the concept of like a Mint banking app, and just applying it to the healthcare space, where you can use any sort of third-party app and be able to connect it through an interface to your hospital system data, and then basically giving patients more ownership. The idea of this being that patients are going to be more engaged, more ability to kind of look up what their best kind of healthcare access points are, maybe make some financial decisions around that. So really opening up to say, the data that we have within our healthcare system is really patient data, and sort of answering that question or that call that patients have had that said, give us our data. This is sort of the response to that. And then the second reason I'm talking about this is on the next slide, is around telehealth and virtual care. And so as a result of stay-at-home orders, social distancing, and like lots of concern for hospital capacity, there's been this very quick shift from in-person visits to virtual visits, and that's sort of defined either as video or audio visits. And there's sort of a really great distinction, and we found that within our healthcare system as well, where essentially from one day to the next, you would notice, in-person, 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 and all of a sudden you sort of flipped a switch, and all of a sudden everything became virtual. And that was supported by primarily one, reimbursement changes at the Medicare level. Obviously, money and reimbursement drives some of the stuff that we do. And so they sort of expanded to create telehealth reimbursement parity across video and audio. Two, from a technology standpoint, they sort of expanded the ability of a healthcare system to use non-HIPAA compliant vendors to provide telehealth. So just like we're using Zoom here or FaceTime or whatever other sort of video technology you wanted to use, you could deliver your care over that without breaking any privacy laws, which had not been the case before. And the third part of this is really around trying to address some more of those technology barriers. The FCC, had some cash to give out to folks to support this as well. So if we go to the next slide, we sort of just highlight we were sort of starting off from a challenging place. If we're talking about equity, leading into this kind of rapid change, we knew that, for example, patient portals that have been around for so long, even though most providers offered them, only about a third of patients were using them. And if we looked at the patient that weren't using them, they tended to be patients who were from racial and ethnic minorities or Black and Latinx populations, those with lower literacy, lower income, limited English proficient populations, rural populations, patients with disabilities. And if you look at that group who wasn't using patient portals, and then you look at the group who often has the worst health outcomes, you'll quickly find that they're essentially the same group. And so we're sort of really not living up to the hype of these tools as kind of expanders of access. And we've seen this come up in the telehealth space in COVID-19. So next slide. And so here we found that, this is sort of from cardiology data, but essentially that highlights that non-English languages associated with more than 50% decreased use of telehealth. So really highlighting that disparity. So if we go to the next slide, the question becomes, how do we actually achieve virtual care equity? And so I'll try to highlight a few points over the next 2 slides. So first, at the kind of government federal level, I think there should be a push for reporting of these tools across from an equity lens, so across demographics, so not just reporting how many people are using telehealth or patient portal, but who are those people. A lot of our federal mandates that guide culturally appropriate care, like the class standards, really haven't been adapted or updated to say, what do we do in the virtual care space? What are the interpreters doing in the telehealth space? And the last component of this is obviously expanding broadband access. From a vendor standpoint, I think, really sort of working on trying to engage those Medicaid and lower income populations and trying to develop startups and kind of in the industry space for those populations. And if we go to the next slide. From an institutional level, there has to be sort of a big investment and sort of like holistic approach to, we're not just saying, here's a portal, figure it out. Here's a portal, here's some community health workers going to help you engage, maybe provide you some training. And now we're sort of tracking at the institutional level, who's using this? Who's across language, across race, ethnicity, and really kind of clarifying workflows. Interpreters workflows, for example, in the telehealth space has been a big challenge. From a clinical team perspective, is really viewing this kind of technology, this kind of tools as sort of just standard care and not sort of offering it to certain patients and not based on like your assessment of whether they're going to use the technology or not. And I think, as Lynette was saying, there's a big opportunity for kind of patients and patient advocates to engage in this system. So I'll end just by saying on the next slide that technology and access to technology has really become a social determinant of health, even to a greater extent than it was before the COVID-19 pandemic. And this kind of statement has been echoed by the AMA as well as the American Informatics Association, and I think we're seeing that kind of quickly become important here. So there's a lot of work to be done, but a lot of opportunity. So thank you for listening. We can go to the next slide. Happy to chat at any time. So thanks.
Fantastic, Jorge. Thank you so much for this excellent presentation. I'm really struck by the couple slides back where you lay out for all of us what we can do. I think a lot of times when you get to a really big, difficult conversation like healthcare equity, it's really quick to say, well, if only payers would, or if patients would, or if doctors would, right? But I think there's a lot that we can all do regardless of what hat we happen to be wearing at any point in time. And I hope that, all of us on the line can really think more about how we can advocate for ourselves and for others in our work and even with our own health to really help make technology in the 21st century really help for healthcare instead of widening the gap. We do have a question here. And I think, Jorge, given that you are both a digital health researcher and also a clinician, you might have really excellent insight here. So this is a question asking about a question here from KJ Sturkin. Isn't there a danger about all in-person care? Is there a concern that maybe if all healthcare gets to become virtual, you lose that face-to-face aspect that's involved with care? What are your thoughts on that?
Yeah, I think just like any tool, virtual care or telemedicine has its place. Obviously, there are limitations to it in terms of getting a physical exam, for example, is sort of a classic limitation. There are certain things you can do and you can't. But I think the way that that you can imagine is sort of another tool, right? You sort of see your person maybe the first time in person in your clinic, and maybe your follow-up doesn't need to be an in-person. It could be a virtual care follow-up. My wife, for example, she sees a neurologist, and her neurologist visit was supposed to be in person, sort of a follow-up just to discuss some results, and she just got a message saying, "Oh, we're switching this to virtual care." So I think there's the correct, just like anything else, there's correct use cases for it. I suspect my sense is that we won't ever be in a place where everything is virtual all the time, because there is that component of being able to see someone in person. There's only certain things you can do in person. But I think I recently chatted with a colleague, and he sort of told me this story, and this is just anecdotal, but this idea where he pushed out to a patient a text being like, "Hey, your appointment's scheduled for right now. Why don't you join this video call?" The person joined the video call and was like, "Oh, I had actually forgotten I had a visit today, and the only reason I knew was that you reached out to me and came in." And so usually in sort of our non-virtual care world, that would have usually gone down as like a no-show visit, and the person may have been lost to follow-up and all these things. But because of this, we were able to sort of increase access and say like, "Hey," the person was like, "Oh, I was just able to jump on just like that." So I think that's the power of it. But I agree that there's nothing is ever going to be sort of purely one way or the other. It's just another tool in our armamentarium here that we can engage.
Great, Jorge. Thanks for that insight. Yeah, I think that's true. I think sometimes there's a hesitance to adopt digital health, digital medicine products with the idea that we're going to completely remove that sort of face-to-face compassion that we can get with healthcare providers. But I think that whenever we have new tools, it's a great way to enhance all kinds of healthcare, including even face-to-face measures too. That looks like our time for today. Fantastic presentations from both Lynette and Jorge. Thank you both so much. And so there's lots of questions too, and a lot for us to think about. Now, to continue this conversation and to remain connected with Lynette and Jorge, do feel free to reach out on Slack. You have their information here, as well as the slides will be made available when they have graciously made their emails and more contact information available. So thank you for everyone on the line, and thank you especially to Lynette and to Jorge. We really appreciate it. And if you have any ideas for any future topics, feel free to reach out to us here at Dime and to me. And thank you again for your time. Thanks, everyone.
Bye.